Good afternoon, everyone, and thank you for joining us today for our webinar sharing one of the 3 case studies from our upcoming report, Driving Speed to Value, wherein Jennifer Rogers examines 3 different approaches to population health management strategy and digs into 1 case study example of each approach. We're excited to share with you the story of the Marshfield Clinic Health System today, one of the earliest implementers of a PHM strategy. You can download the slides from the handout section and feel free to submit questions throughout the webinar via the question dialog in the GoToWebinar control panel. For those of you watching the recording, the link for the slides is in the video description. We will share the link to purchase the report with everyone once it is available, as well as send out these slides to all attendees and everyone that registered following the recording editing process. Our team here at Chilmark Research is united by the belief that effective deployment and use of IT is essential to modernizing care delivery and ultimately improving the patient journey to health. Understanding the emerging trends and technologies to enable this is what drives our choice of research topics each year. It is our goal to provide objective, forward-thinking insights that will help create an informed market of stakeholders that can truly impact our care delivery system here in America and abroad. Today's lead speaker is Jennifer Rogers, the lead analyst for our population health management domain. Jennifer joined us last year after leaving Optum, and she has been a great addition to the team. She started her career on the front lines as an RN in surgical intensive care. She has since worked across the continuum of clinical care management for the past 25 years with a focus on PHM at large national health plans prior to joining the Chilmark Research team as our lead population health management analyst. She already published our ACO Enablers report back in February and is currently working to finish up this PHM case study report, while simultaneously starting work on a new report on utilization management with a specific focus around prior authorization, which will be released later this summer. The first speaker that we have from MCIS is Kate Knitzer, the Chief Informatics Architect for the Marshfield Clinic Information Systems. She has overseen the analytics practice since 2000 and has implemented an analytics framework to support the development and implementation of PHM that includes quality metric evaluation, provider-patient attribution, outcomes evaluation, and identification of the at-risk population using predictive analytics, as well as key performance indicators, patient experience, revenue cycle, and other analytic applications. Kate is currently working to embed analytics into electronic health records. She has an undergraduate degree in computer science and holds a master's in medical informatics from Northwestern. Our other guest from the Marshfield Clinic is Becky Birchmeyer, who is an RN and has a master's in nursing and is now the Director of Care Management and Value-Based Care at the Marshfield Clinic Institute for Quality, Innovation, and Patient Safety. Prior to her role as director, she supported pediatric initiatives system-wide in IQ-IPS as a pediatric clinical quality nurse. She received her graduate degree from the University of Wisconsin-Madison in nursing education and her undergraduate nursing degree from Virbo University. Her professional experiences include obstetrics, public health, nursing education, pediatrics, and quality improvement. And following up on our last webinar, we are still promoting our Convergence Conference. Most of our webinars this year will be related to this topic of convergence, which is around the idea of payers and providers collaborating more directly to provide better care in the evolving healthcare landscape that we are currently experiencing around payment reforms and new contracting models. This event will be hosted October 4th through 6th at the Hyatt Regency in Boston. It will be a day and a half of excellent speakers from across the care continuum discussing what they have seen and what the struggles and the benefits are of implementing these types of strategies. You can find more details or register by going to chilmarkconvergence.com. Without further ado, I leave you in the very capable hands of Jennifer Rogers.
Thank you, John, and welcome everyone. Thanks for carving time out to attend today's webinar. What we'll cover today is why did we delve into this particular research topic, set the backdrop for that, share some high-level conclusions that we came to, but spend the majority of our time today with our guest speakers from Marshfield Clinic, and as John said, delve into one particular case study that is highlighted in the upcoming report that we'll be publishing. So this is my favorite. You might recall from last time. He's the Pondering Bear. We always try, as John said, to make our research very relevant to what is going on in the market. So it's of value to people to pragmatically be able to use it and further the care experience for consumers and providers and payers and the entire industry alike. So why we chose this particular topic, right, is we hear so often this drumbeat that there are so many different paths to follow, so many different models, so many different ways to think about population health, that we were curious and wanted to identify, are there some best practices, which there are, right? There are best practices being identified across the industry that can really help a healthcare organization deploy a model quicker and more quickly realize speed to value. And so that's what we're really trying to do, is say, is there a quicker way to get there? Or is it really complex? Is it as complex as it sounds? So this particular report, we took 3 very divergent organizations. You can see here, and this report goes into all 3 in some amount of detail. Trenton Health Team out of New Jersey took an approach where they really are able to rely on a single PHM vendor to deliver most of their strategy, and that's highly unusual, really, in the industry. Partners Healthcare out of Austin has employed a great many IT vendors to help enable their PHM strategy, and yet they still do not hesitate to build what they need if they can't find it on the open market. And then Marshfield Clinic, who's with us today, you'll hear they developed a proprietary EHR and integrated PHM platform to enable their overall population health strategy. So very, very different approaches. And then what we did was put in additional research, and we're able to come up with best practices, as well as in the report point you to some other no-cost best practice resources that are emerging in the industry, and we expect you to see more and more of these over the next 12 to 24 months. I think the industry, while it's still immature with pop health, is really gaining some speed and momentum now that we're 5 to 10 years into it, depending on the organizational journey map. So some high-level research conclusions here really are that while you might feel like a lot is out of your control, that we identify a great many factors that are within an organization's control as they go to think about how to deploy and monitor their PHM strategies. And that the most successful organizations don't just relegate their pop health, even if they start small, don't relegate it just to one department. Really, we call it enterprise-level thinking, evolve and involve your senior leadership and throughout the whole organization, and you will generate even better results than you would if you keep it contained within a certain department. We always know that you want clinical and business and IT folks together when it comes down to kind of mid-level business strategies and tactics. For sure, you want a deep partnership across clinical and business and IT. But at the very high level, when you first start, we still are finding it's an age-old best practice. Make sure that you think about your clinical and business strategy. What are you trying to accomplish before you start pulling in some solutions, right? So you have to figure out what are you trying to solve for before you pull in your solution, which tends to be your IT enablers. And that, again, even though I mentioned the market is immature, by choosing at least one key vendor partner, and then knowing that you might need others depending on what you identify your gaps and needs are. Just be aware that we're not yet at a maturity in the market where we can always say that one vendor will do everything that you need. So I mentioned best practices. They're quickly evolving, and just be on the lookout for them, because what we have found really is that still too many organizations work in a silo, and they are figuring out again and again the same things from scratch when other organizations have already found a kind of a way forward. So really, it's really important to look across the industry and see what are some best practices that are out there. And by the last high-level conclusion, again, because PHM tends to start small in organizations with small amount of staffing or small amount of intervention, a small amount of data, and then it grows and it evolves and it iterates. Because of that pathway, it is often happens where an organization forgets to deploy tried and true business methodology, where you document your work as you go, you document your gaps, you document how you're going to measure success, and you establish a very disciplined project management methodology. Again, organizations that stick to more of a disciplined approach on how they deploy their PHM model tend to save time in the long run, because then they don't have to go back and build those artifacts from scratch. So without further ado, though, I want to spend the majority of today, as I mentioned, with my friends from Marshfield Clinic who joined us for our webinar today. And we'll go through a review of their model, including their technology enablers for population health, and summarize some key lessons learned that they've learned along the way. So we know that when you think about how we said when you're deploying PHM, how you do it depends on where you started. And so I'm going to ask Becky if you can give us a flavor for the background about Marshfield Clinic itself, because you really have to understand where an organization is, how they're structured, and what community they're working in to be able to understand the approach they've taken. So it really puts everything else in context. So Becky, can you tell us, for those not familiar on this webinar, a little bit more about Marshfield Clinic?
Absolutely. Thank you, Jennifer. Marshfield Clinic Marshfield Clinic was founded in 1960. In 2012, we became a fully integrated health system. So changed our title to Marshfield Clinic Health System. We, as a system, have our own provider network. We have our own IT platform, which we'll hear more about in this webinar, and we also have a health plan. As you can see from the map, our area of coverage is largely south central northern Wisconsin, and we do have some patients that seek care within our system from the UP of Michigan as well. In addition to outpatient care, we provide acute care, urgent care, dental, lab, and pharmaceutical care as well. We have 700 providers in 86 specialties, and we take care of 375 unique patients to account for 3.7 million clinical encounters annually. The Marshfield Clinic Health System began their population health journey back in 2004 when we became a CMS PGP project participant. Since then, we joined with our Medicare Shared Savings Program, Track 1, and that has been in place since 2013, in which we take care of 30,000 lives, ACO lives. There is an IQIPS underpinning to the system of care. So IQIPS stands for the Institute for Quality, Innovation, and Patient Safety. And essentially, we support Marshfield Clinic in ensuring quality of care, ensuring evidence-based practice, work to improve the patient experience, and we pay particular attention to the cost and utilization of care as well. We also are moving more into the acute care realm. We currently have 2 hospitals, and we are moving forward with expansion of hospital care throughout our geography. Our geography is largely rural, and we are really focusing on the needs of our population by expanding skilled nursing facilities as well. In the last year or so, we actually started up 3 skilled nursing facilities, which we're calling the Comfort and Recovery Suites, where we're really taking more of an innovative approach to make sure that our patients are being cared for in a setting that's very comfortable for them, as well as extending that into a hospital at home program.
All right, thank you. And while you're giving us some background, can you tell us then about the care management model and just at a high level how you think about care management there?
Absolutely. Marshfield Clinic Health System approaches clinical care as a multi-specialty system. So all members of our care team are involved to improve the health of our population. That improvement care model is largely supported by our department, by IQIPS, to make sure that we are working through continuous quality improvement with our care teams as they deliver care to our patients. So our Marshfield Clinic Health System mission is to create healthy communities through accessible, affordable, and compassionate care. And for that reason, we really take a view of population health to incorporate our full population. So we, in essence, care manage our full population, and we also do care management of select populations. We work largely to engage all patients attributed to our providers within our population. And based on data that we receive from our analytics, we also identify select populations that would benefit from more intensive, more continuous engagement in their health care. So with our population health focus, we essentially look at our patient population regardless of payer. Even as a Medicare Shared Savings Program, when we look at our analytics and how we implement new programs to impact the care of our population, we do that regardless of payer. So as an example, if we're looking at improving blood pressure control for patients with hypertension, we take the approach of looking at our full population, knowing that if we take that approach as a system, it will bring everyone along and that the care will be consistent overall. We've also found over time that by engaging our full care team, and by that I mean not only our primary care providers, our specialty providers, and all of the ancillary services, support care teams that would really benefit from being engaged in the patient's care. We have found that providers and staff are much more engaged. We find that by providing reliable, real-time data, the provider is also engaged. They know their population, they know the patients that potentially are starting to fall through the cracks, and they leverage their care team to ensure that we're recalling those patients back into the care that they need. We also use a bit of an innovative approach in using our what we call clinical quality coordinators embedded within our primary care sites to help look at that population health list and recall those patients into care, whether that be an office visit or that be recalling them for the services that maybe we've identified gaps in overall.
All right, thank you. And Kate, can you give us some background, though? We know, again, that population health as a clinical and business strategy is highly, highly enabled by technology, right? It's how you bring it to life and make it happen. So can you tell us about the technology at a high level, how you think about that? And I know then in this webinar, we're going to go into more detail on the components for Pop Health underneath that, but at the highest level, give us a flavor for your technology approach.
Sure. So Marshfield Clinic Information Services, MCIS, is an operating division of the health system, and some could argue that we've had portions of our EHR in place dating back to the early 60s with the electronic collection of diagnosis codes, but really more formally since 1985, long before high tech. We've continued to develop a robust and mature EHR with the health system, supporting many of the initiatives around value-based care, including meaningful use or MACRA, Pop Health, and PCMH, as well as many other applications. We have re-platformed the last couple of years. That has allowed us to modernize our systems, and we're really excited to be implementing our new platform throughout the system this year. We have developed a framework for dashboards, including Pop Health, with drill down capabilities that allow you to drill down to the patient level detail and then the ability to take that user into the EHR as needed. And this has really provided confidence in the results for the physicians and the care teams. We work very closely with our iQuips team. I like to think of them as kind of the conduit between IT and the care teams. They help the end users understand the results and helps them make action plans as needed, and then we work with them as changes or improvements are needed to maybe better define evidence-based guidelines or make them more applicable to our practice.
And now let's go into then a little bit more detail on the subcomponents that enable population health, and we'll go into the EHR, how you ingest data, the analytics and reporting, and then care management and patient engagement, really how you use technology to enable all of those portions of Pop Health.
Okay. So as mentioned, we do have a robust EHR with highly structured data that is codified behind the scenes, which enables our analytics and decision support within our systems. Leadership many years ago had the foresight to use a common medical history number among all the domains in our electronic health record, so including our radiology systems, our lab systems, and our clinical products. And that really allows us to have this comprehensive view of what is occurring among our patient populations, and so that's really been key for us. And then the codified systems, follows the national standards. And the funny thing is, we've always used some kind of standard, which has allowed us to easily transition to the national standards. So while we had our own set of standards way before the national standards existed, we have been able to migrate over to those national standards and adopt them as they continue to evolve. And then if you want to move on to slide 16, I'll actually walk through this diagram that kind of summarized in the previous slide. So in our environment, we have the transactional data sources, which you could think of as your patient demographics, your provider demographics, your problems, the patient's diagnosis codes, the patient's problems, the patient's procedures, their lab results, their radiology results, additional structured data collection that takes place in the electronic health record. And then we extract that information and put that into a staging area, and then we further transform and load that and put that into an atomic level data warehouse. Now, a lot of people think that once you have that information available in a data warehouse, it does all kinds of magic. What we found out in the early days is that really, it's a bunch of tables with a bunch of columns and rows. And so what we do then is, from the analytics side of things, we extract, transform, and load that again into more subject-focused areas and create data marts that are available for the end user and make applications available on the portal to access that information and make it more meaningful to the customer. So those data marts are things like a population health management data mart, or a key performance indicator data mart, oncology metrics, so on and so forth.
When we look at how we use technology by Population Health Management Component, I mentioned earlier that we really take two approaches to population health. We look at our population as a whole and identify that we need to manage that population as they are attributed to our providers within our system. And then we're also able to break down that population into more specific chronic care management programs. From our population as a whole, we are extremely fortunate, we believe, to have our IT and our analytics teams to help us frame up the approach that we want to take to identifying patients, and then also building out the solutions so that we can manage that population appropriately. We look at our population as a whole from a preventive standpoint. What preventive services are they overdue for? We look specifically at chronic conditions for our whole population. Who is diagnosed with hypertension, with coronary artery disease, with diabetes, with COPD, with chronic kidney disease, heart failure. We're able to identify those populations and then also identify key measures of focus. At times, those key measures of focus are defined for us externally. They may be measures that we're reporting out through HEDIS, or we're reporting out through our CMS participation, or NQF measures that align. But overall, our care team looks to see what do we need to do for our patient population, and we're able to work with our IT team to build out those measures. What that enables us to do is build tools that are embedded in the EHR that help us do pre-visit planning, that help us identify what services are due at the point of care. And furthermore, we're able to use our population health management dashboards to pull up our patient list, as Kate has mentioned, at the level of the system, at the level of our centers and our departments, broken down into our providers, and then looking at that patient population and pulling a full comprehensive patient list to be able to work through. We leverage our care teams, our medical support staff, to a great degree to look at those patient lists and work through those lists to make sure we're recalling patients into care. To break that down into more specific populations, we're able to look at our population to see who is in need for more intensive intervention. What is the cost of care? What is the utilization? Are there populations that have higher admission, readmission, ER utilization? What is the patient experience for those populations? So we tend to ask ourselves, who are my patients? What comorbidities exist? What are those gaps in care? Do I have access to the data to better understand that population? And if we don't have that data, we work with our IT team to build that out. From there, we're able to develop and bring to our leadership the need to have care management programs in place. We currently have a number of care management programs, and I'll highlight our heart failure center, that over time we've been able to increase our population to 1,300 patients, and we have been able to really see impact and outcome for that population that has, by the data that we were able to pull through, has improved their quality of care, has improved their experience, and has decreased their utilization of hospital and ER services. We also have anticoagulation services, we have osteoporosis and bone health, and we're looking at expanding future care management programs into other chronic conditions as well. As far as referrals, we again engage with our care teams to a great degree. Many times for our care management services, those referrals are coming to us directly from our primary care and specialty care teams. In other regards, our whole system, because we have an integrated EHR, and as patients come to seek care, other ancillary services have access to that data, we're, as a whole, as a system, we're able to identify those patients that would really benefit from having more intensive intervention.
Okay, so I'll talk a little bit about our roadmap, and that's something that I'm really excited about, is our care management roadmap with our new EHR platform. So we've already integrated Pop Health into our product real time. And what we've done is positioned ourselves to build a Pop Health-like feature over the top of our EHR modules within the EHR. It will allow us to identify different patient populations, identify the tasks that are needed to manage this population, and then use the EHR as if it was a dedicated care management system. So we're really excited to push this forward.
As we look at patient engagement, again, we're able to use technology to a great degree, again, for our full population as well as engaging our population that's care managed based on chronic condition. We engage our patients in the patient portal utilizing secure messaging so that there is that continuous interaction between not only the patient and their primary care provider, but also their specialty providers and expanded care teams. We also looked at that population to see what additional care model services would benefit their outcome. And so we really look at expanding access through telehealth and virtual care services. We really use that way of thinking to expand more innovative approaches to care, such as using a hospital at home, expanding our skilled nursing facility access within our health system. So we, again, largely rely on our integrated EHR, embedded analytics, and interacting with our care management team as well as our IT teams to identify which patients would most benefit from enhanced services.
Okay, so I'll go ahead and talk about the portal in the next couple of slides. What I wanted to talk about here is really how we have worked really hard to make sure that we are aligned no matter what or where you are in our platform, whether you're using the patient portal or whether you're using population health or whether you're seeing that patient at point of care. We use evidence-based guidelines and other best practices that may not have, an evidence-based guideline available. And we make sure that no matter where you are, it's telling you the same story. That, I can admit that that wasn't always the case, and that's something that we've learned over time, that when you're telling the patient one thing on the portal versus, point of care and they're not aligned, that becomes very confusing, and a lot of time is spent on why are there these differences. And so we've worked really hard over the last couple of years to make sure that we have everything aligned. So here on the screen you can see, you're logged into the patient portal, and any names that you see here, this is all taken from a test environment, so they're all test patients. There's no actual patients identified here. But you can quickly see some key measures, blood pressure and your weight, cholesterol, tobacco use, and those are configurable to what you want to be able to see there. We also show some of the reminders, such as breast cancer screening, cervical cancer screening, and then your visit summary and your care plan is available to you. So if you go on to the next slide, another screenshot of the portal, you can see some diagnostic conditions that you may have and whether you're at goal or not at goal for those conditions. Here you can see details of your care plan and some instructions that the provider may have generated. We like to use the radar charts in our Pop Health portal. It allows you to see a lot of measures in a very concise view, and where the outlined blue is, that's the goal or the benchmark, and then the green is where your actual results are. So wherever you have some blue, it means that there's areas of opportunity there. You can drill into the patient level detail, and again, all of those are aligned with everything else, whether you're looking at your A1C values or your blood pressure control. It's telling you basically the same story. And if you go on to the next slide, this is actually our order sets and our recommendations. And again, everything has been aligned and is consistent.
All right, thank you, Kate. And that is a very robust approach from a clinical standpoint and technology standpoint on how you all think about the population that you're honored to care for. So now I'd like to spend some time, if you can tell us what kind of outcomes you've seen as a result of all of these efforts.
Absolutely. So as we utilize our population health dashboards, and I've worked with our care teams to understand the patient populations, our attribution logic, and what that data was telling them, we did see that increased engagement. Providers and their care teams at any given time can access the population health dashboards again and identify their patient panel and also identify the gaps in care. So what we can see over time is that we have realized drastic improvements in our measure performance. So this is a quick snapshot, and there's many more measures than what are listed here. And when we first started measuring hypertension blood pressure control, we were at a 49.8% control rate. We are now at 83.9% of our patients meeting goal for that particular measure. We've been able to increase our pneumococcal vaccination rates. We've been able to increase our engagement with tobacco use and cessation, diabetes-related measures, A1C, LDL, foot exam, and our preventive screenings, breast cancer screening and colorectal cancer screening. So what we tend to do from an IQIP standpoint, from a population health standpoint, is we tend to use stretch goals. So as we identify where are we at, where do we want to be in comparison to our external reporting benchmarks compared to how our internal measures are really transpiring. We work with our care teams to achieve those goals. We work that through with continuous quality improvement, specifically PDSA cycles, and we continue to keep things on the forefront strategically for our health system so that no matter if the patient is seeking care in our primary care teams or they're coming in through our specialty care teams, the same data, the same opportunity to look at that patient's care gaps are realized. So we're able to really leverage not only primary care, specialty care, but also any other services the patient would be presenting for within our health system. We have, just to really focus in on one particular improvement opportunity, hypertension with blood pressure control has been a key system priority for the last 2 years. We started with our primary care teams to really put some focus on that. We've expanded that to include specialty cares, specialty care providers making sure that referrals are occurring, that blood pressures are being completed accurately. What we've seen is that our control rate increased to 83.9% of our patients. The story that we try to tell with that is when we look at our patient population, we now have an additional 20,800 patients at goal. When we look at evidence and we look at the number needed to treat to really prevent one heart attack or one stroke, we would need to treat 50 patients between 18 and 59 and 18 patients 60 years of age and older for 5 years at goal to prevent that one heart attack or that one stroke. So when we look at the fact that 26.2% of our population that has hypertension is in that younger age bracket, and the 73.8% are in that 60-plus age bracket, what we're able to convey to our care teams is that we have been able to prevent an additional 1,540 heart attacks and an additional 385 strokes. And when you look at that as a patient from a patient-centric perspective, we know that that is our ultimate goal. We want to do better for our patients, and we have a unified approach in that. When we look at it from a cost and utilization perspective, that also equates to savings. So preventing those heart attacks and strokes is an overall realizing a savings of $20 million. When we look at our specific care managed population featuring Heart Failure Center, we have over time seen drastic decreases in outpatient hospital use, ER visits, urgent care visits, inpatient hospital, and readmission. So if you look at this graphic, essentially it's looking at from the time of enrollment over the course of days post-enrollment. What we typically see is when we receive the referral from the care providers, the patient may be in a more compromised state. They may have been hospitalized, they may have been seen in the ER, and so our care management teams, which includes the nurse practitioner and RN, work very closely with that patient to help get them the services that they need. So initially within that post-admission time period, there's a lot more activity happening, a little more work to get the patient stabilized. But once we get them enrolled in the program, we're able to use heart failure center dashboard metrics then to work with our patients, and the drop-off in utilization is drastic thereafter. We're able to maintain those patients in a healthier state. We're able to be much more proactive, educating our patients according to their symptoms, using that data to recall those patients as needed, and really intervene with them in a means that's much more patient-centric. So not bringing them into the hospital per se to have care done when the patients are really much more compromised. We're able to bring them into the clinic for IV diuretics. We're able to engage with the patient telephonically and just make sure that they are adhering to their medication regimen, so on and so forth. So we have seen great success not only with our population health management strategy in really managing our population as a whole by using analytics, but when we look at our care management programs, we've also seen very similar outcomes that we believe really enhances the care of our patients.
That's a very dramatic difference there over time. So I want you to share with us, because I mentioned at the beginning of this webinar, right? Every organization has a different starting point. Everyone has different capabilities they bring to the table. Everyone's operating, you know, in a different region with a different local community. There are so many variable factors that different organizations, right, can attribute the success that they are achieving to different factors. So what do you really attribute some of your successes to?
We have found great success in partnering with our IT team. So really, as Kate had mentioned, it's really a collaboration between not only the care teams that are delivering the care, it's utilizing our IT to help bring that data in front of us, use analytics to help us understand our populations better, and as an IQIPS team, helping support our care teams as they work to improve the care of the population. So what we have seen is system-level improvement. So when we bring the evidence in front of our care teams, we are able to really approach improvement projects from a system level, engaging all levels of our care teams. We also see great benefit in expanding care management programs as a way to take better care of our patients. Again, using analytics, knowing that population that would best be served by enhanced, more focused intervention. So what we truly have seen is as we increase our care management programs based on those populations, we're able to see the outcomes that I just showed to you for Heart Failure Center. We also really feel that leveraging the full care team is a key to success. So no matter what size organization you are, whether you're a multi-specialty, large, geographically spread organization, or you're a single clinic, really utilizing the care team, leveraging them to their fullest capacity. We have a very engaged group of medical assistants, nurses, and as I mentioned earlier in the webinar, we've created a new position for clinical quality coordinators that have a focus just on population health management strategies, looking at the data that we have in front of us, again, because our IT team has a very dynamic population health dashboard, and really proactively reaching out to those patients and making sure that we're bringing them into the care team, that we're engaging with them in a way that they want to be engaged with, and that we're much more proactive about their health, keeping them focused on preventive strategies and keeping them out of the hospital acute care settings if at all possible.
Yes, so well, we have a lot of area of experience with our IT, and we can leverage that 50 years. It's really that partnership with the business that allows us to be agile and meet the needs of the business. So it's really, I can't emphasize enough, it's really that partnership between IT and the business. And then delivering our next generation EHR. We're very excited to be implementing that this year and allowing us to really look ahead and meet the needs of value-based care as it evolves.
Fantastic. And I know our audience has heard some of this throughout the webinar, but if we could just summarize, call them lessons learned, call them recommendations for other organizations. Would one of you like to kind of recap then, or both of you, I guess, some of the recommendations you might have for other organizations to consider?
Absolutely. So what we've learned is that we need to make sure that we are addressing our patients' needs no matter where they enter our system. whether that's a phone call into our system, whether that's walking into a primary care practice, establishing with a primary care provider, or coming into a specialty care service or an ancillary service. We have opportunities at every level to engage our patients and really helping to make our population in a healthier state, really improving the health of our communities. We also very, very strongly feel that we have to take a team-based care approach. We know that patients feel satisfied when they walk into our dental centers, and our dental centers are able to identify that there's a gap in care, and they're making that connection for the patient back into our primary care setting or back into our specialty care setting. I think sometimes our patients actually feel like that's magical. How did you know that I had this particular need? And it's because we have our integrated EHR, that we have it built in a way that we know is really ensuring that our patients have the best care possible. So again, no matter what size system you're working in, there are great opportunities to work with your IT to make sure that the patients are not falling through the cracks.
And from the technology point of view, so historically, we've been reporting on Pop Health for over a decade, really. And while we've made great strides there, we may have plateaued maybe a little bit. And now being able to actually integrate Pop Health with the clinical workflow, we're optimistic and looking forward to looking at results in a year from now and seeing that, while that patient is actually in the office, you can address their concerns right then and there rather than getting a report a month later or 3 months later, as some other systems exist. So integrating that with the clinical workflow is key. Enabling the providers to drill through to their patient list and actually seeing who those patients are that are at goal, not at goal, and being able to act on that has proven very successful for us. And then taking care of your data and managing your content well. So I sat in on a 4-hour webinar 2 weeks ago, sponsored by ONC, talking about interoperability and population health management. And one of the physicians really echoed this bullet point in that he said, when he went to school, nobody told him that he had to worry about about terminology or the content. When he practiced or when he was in his residency program, again, nobody told him that he needed to care about his terminology, and he's saying, today we really need to care about our terminology and how we code things for structured data collection to make that interoperable, and so we can understand that continuum of care for the patient. And so, it pays off to take care of your data and manage your content well. And then ensuring that the clinical decision-making prompts are programmed to be patient-centric. So while we use evidence-based guidelines for care, we do allow the physicians to make them patient-centric. It may not be applicable for the patient population or for a specific patient to have breast cancer screening or have their A1C at goal because of other comorbidities that are presenting itself. And so allowing the patient-centric care is also been key for us.
All right. And we know Pop Health is not a destination. It is the proverbial journey. And so what is next on the horizon for you all at Marshfield Clinic? We'll just wrap up with kind of what are you thinking about as you look forward into the future? Again, you've given us a flavor for some of that, but could one of you tell us what's next on your mind?
We really are looking at our health system as having the capability of delivering care along that continuum. So with our integrated system, we're able to focus on that continuum from prevention and focus on the population health as a whole to offering acute care services and coordinating the transitions in between. So we know as a health system, having the data in front of us, focusing on it, whether they're seeking care in our outpatient setting or in a hospital setting or in a skilled nursing facility or any other point of entry, we have an opportunity to continue to work for making sure that that coordination is defined, that those transitions are seamless, and that the patients, when they seek our care, feel that coordination, that they know that as a patient they're being cared for, and that we have a good understanding of their healthcare needs. So we have multiple levels of support for our patients with this integrated system, including our payers. With our technology, analytics, and integrated EHR, we can ensure coordination between all levels of support within our healthcare system. And our aim is to continue moving forward on that journey, continue using our analytics and our IT team to the greatest degree of ensuring our populations are well taken care of.
And then just wrapping up, this goes back a little bit to really the roadmap discussion, where we're collecting this information at point of care, and we're listening for specific events and transforming that real time, so we're able to present this information back to the provider and the care teams real time. But at the same time, we're also using our enterprise data warehouse to help build out basically our risk model. So we're using information that's external to our EHR that's being collected, so we can use that information as well. And then really having a strong informatics platform that supports that model up on top, whether it be, your best practice guidelines and your value sets, and then turning those into reminders or order sets, clinical rules, different types of alerts, as well as measures, and then the different products, being aligned there to provide patient care plans, workflow templates that help facilitate the care of that patient, being able to provide those care reminders, and then having Pop Health and the patient portal. And so this is where we are going, and we're very close to being here today. So we look forward to looking back a year from now and seeing how it may have made a difference.
All right. Well, thank you. I want to thank Becky and Kate from Marshfield Clinic joining us with Chilmark Research on this webinar today, and I really hope everyone found this helpful, whether you're building a Pop Health model or you're evolving an existing one, again, that you found this information helpful. So we'll just, John, if you can help us open the line up and see if we have questions in our remaining minutes.
Absolutely, Jennifer. All right, so our first question is, what is the best practice to cross the chasm from program pilot level PHM into enterprise level PHM?
So I think that a lot of that, again, is having IQIPs partnering with IT as well as the care teams, and taking those evidence-based guidelines, making sure that they're applicable to the patient population, and creating system-wide initiatives with IQIPs really kind of being that the partner that helps care teams understand those results, help creating PDSAs and continuous improvement processes. Becky, you have more on that?
I would say too that having our population health dashboards formatted in the way that they are, that we're able to take a measure and really look at that from multiple levels within the system. So define it at the system level, being able to break that down. We're able to work with IT to make sure we have multiple views within that population health dashboard. So we not only can look at how are we performing at each level, but we can also use comparison data to see how is one area doing better than maybe another area, and what are those best practices. So we really engage our care teams in looking at that data and looking for opportunities to improve their practices. And what we have found over time is our care teams have become more accustomed to the dashboard, having that analytics at the point of a finger click away from them. They are able to reach out to us and say, I see this center or this provider is doing very well. Can you help me get there? So I do think that we can deliver that performance at the individual level, but I think you really need those dashboards. You need that analytics team to help you look at that bigger picture and use that bigger picture to really help make sure that the system is all moving forward in a way that is taking care of our population in a more consistent standardized approach overall.
Great, thank you. I think this next question is more targeted towards Jennifer. Has your research or case studies revealed any significant benefits on working with an EHR vendor, PHM solution versus third-party or homegrown? What are the pros or cons of going with an EMR vendor integrated solution?
Let's see. So the case studies themselves were, as I mentioned, they're very variant. From Marshfield Clinic able to use their own and hopefully demonstrated here today. And as Kate said, we could do this again next year and hear about how bringing the PHM right into the point of care, what that might do to a difference in outcomes, right? Certainly will make the process smoother, and at the end of the day, too, we care about the outcomes. So I think the industry's a little early yet to be able to point to specific outcomes and say, well, if you do it this way with this technology framework, you'll get better results than the other. Intuitively, right? Intuitively, you'd want to say bringing it all into the point of care would be the better provider experience, better patient experience, and hopefully result in better outcomes. But there was no actual research, again, at this stage of maturity in the market that would indicate definitively that one is better than the other.
Thank you, Jennifer. The next question, I have to read the way that it was written. Patient-centered PHM initiative where IT and clinical come together for a common cause? Wow, impressive. Talk to me about potential pitfalls, politics, and fiefdoms, etc.
Yeah, this is Becky. I think the reason why that happens in our system is because we are continuously focused on patient-centered care. So whether it's IT coming to the table, or IQIPs coming to the table, or pulling in our care teams to the table, we always have to come back to why are we here? And we're here because we need to make this work for our patient population. They are at the center of all of our efforts. And so, from a politics administrative standpoint, I don't perceive that. I really feel like our culture has been in alignment with our mission. We're a rural community. We're, again, very geographically spread out. But we're made up of small communities where our patients are our neighbors, they're our friends, they're our family members, and we know that when patients come to seek care in our system, we have to work together to make this work, and we don't want those patients to fall through the cracks. So it has been a great relationship, I think, between our IT department and our operating teams to make this work for our patient population.
Great, thank you. The next question is, popular perception is that the PCP is the primary point of entry for PHM. Can you expand on your findings that it is specialty care?
Yeah, and again, historically, as a system, a lot of effort and focus was put on the care of our patients when they seek care within the primary care practice. And we work very hard to make sure our patients are connected to a primary care provider. The reality of our life in northern and central Wisconsin is that patients are coming to us from a great distance. And the reality of their world may be they can't come to us to see primary care on a regular basis, but our specialty services may be the only access point they have for their cardiology care or their oncology care. And so we really, again, encourage our patients to make sure that they have a primary care provider. If that primary care provider happens to be outside of our system, we, again, work to collaborate with those providers. But we see great benefit in also making sure our specialists have access to the data, because we can't be as certain that when a patient's going elsewhere that they're being prompted to make sure they've had their colonoscopy done or that their A1C is being managed well. As I mentioned, we even have dental centers that are keened in and focused on definitely the components of the patient's care that are outside of their dental needs. And so we really are shifting our focus to not just making sure that everything is centered around a primary care model, but making sure that, again, no matter where the patient accesses care in our system, that we manage that patient's needs with a population health focus in mind. And so can I say that we're 100% there, that we don't have opportunities to make sure that we are doing that better? I can't say that, but I can tell you that we have great levels of engagement. We're working very closely with our specialty care members, and we are hearing feedback from patients that they're quite pleased that they feel that their care is being coordinated between primary care and other services within our system.
Yeah, and one thing that we do is, we have an attribution model in place, and so we attempt to attribute that patient to a primary care provider, or to one primary care provider, whether it be internal or external. They'll also be attributed to a specialty care at the same time, and so that encourages collaboration between your primary care and your specialty.
All right, thank you. So we are now at 2 o'clock. I think we have time for maybe 2 more questions, and then we'll have to wrap. So here is the next one. In your set of data marts, can a patient occur in more than one subset? For example, a patient who has been successfully treated for cardiovascular reasons, hypercholesteremia, for more than 10 years, and who subsequently developed stage 4 prostate cancer. Would they occur in multiple subsets?
Yes, absolutely. So I know a lot of areas look at patient registries that are very specific to a disease state. We take a little bit different approach, and we look at all of their comorbidities. And all is a little bit of a stretch. It's those, that we are paying particular attention to or have initiatives around. It's impossible to, I think, cover every disease state. But we look at the patient more holistically, whether they have diabetes, coronary artery disease, heart failure, what have you. And that, I think, allows us to treat the patients more holistically rather than just their diabetes.
And I would agree with Kate's assessment. We do take a holistic approach, and we're very excited looking at our upcoming new platform that we're able to even expand our ability to address even more conditions. So we do have key areas of focus, and we're continually growing and continually working to expand based on the condition the patient's presenting with. How do we ensure that we are meeting the needs of the patient not only holistically, but also meeting very specific needs based on their condition?
Great, thank you for that. Okay, last question. What challenges did you face integrating with EMR systems across your clinics, hospitals, HIEs, or other health systems in Wisconsin?
So we do have a fairly mature HIE system in place. We can, take in any CCDA, and we can send out any CCDA, and so, I don't find that it's really been a problem. I think as long as you are following standards and structuring your data, that really facilitates that interoperability.
Okay, and with that, we have come to the close of this webinar. Thank you very much for joining us today, Becky and Kate, and we look forward to working with you going forward.
Thank you.
Thank you.
And thank you to everyone that joined us and submitted such excellent questions at the end there. That was great. Much appreciated.